No, we're just gonna talk. Let me see, make sure your mic's green. Yep. Is my mic green? Yeah. Okay. I need my booty mug. Welcome back.
Oh, we starting?
To episode 2.
Okay.
It's a casual conversation. We want to introduce our mugs.
Angela gifted me mine.
Hers is Ciolata Ovulata. Mine is a booty.
It's a
The other
tiny
side,
one though.
like it's like a shot glass, and it was $16. And then the other side is a woman's. So I'm like, all right, it's appropriate. We focus on the booty here. But now I want to get her this one. So
yeah, I'll hold it the other way. But I like Ciolata Ovulata.
I think it's cute.
And we both have green tea in here today.
Yes, we did green tea today.
Mm-hmm.
It's early. It's before noon, so we can have caffeine. And actually, no, I've been having caffeine in the afternoon, but only green tea.
Yes, I already had coffee. I
had my huge
can't skip coffee.
Cup of coffee. And then we both went running this morning.
Yes.
Not together.
No, I was in the dark.
I waited till light time.
Mm-hmm.
She tried to find my house, but she couldn't find it. She doesn't know which one is mine.
Angela! I'll yell at 5:30 a.m.
Disclosure, I live with my parents, so she would have woke them up. That would have been great. Okay, so we want to introduce my plants too. Behind, we have Penelope the Palm. We're changing rooms today. We have Piper the spider next to her.
Yeah, she's hiding. There. She's kind of underneath.
She just likes to hang out with everyone.
She likes to be hugged.
Then we have Pam the peace lily. Now Phyllis next to her on the floor. You can't see Pam, but she apparently is a silver. I don't even know. And then we have a new wandering Jew, Beatrice. I love it. So that's our environment today, and we've learned how to do the camera properly. Everything's gonna go really smooth.
Hopefully we're close enough. I
think we are. We're fine.
Well, we're in it.
We're good.
Yes.
We're good. No, it's way better than last time.
Okay.
Okay, so episode 2, we're going to talk about the effects of menopause, and we're mostly going to go into pelvic floor. We're going to go into our specialties first and foremost today, and just really give a good informative talk. Do you want to introduce who you are in case?
Sure, just in case you're tuning in for the first time.
Second episode, baby.
Hi, Mom, again, if you're the only one watching.
Thanks for watching again.
So my name is Dr. Maryhelen Gustafson. I am a pelvic floor physical therapist specializing in the perinatal population, so everything around trying to conceive and postpartum, but also I don't strictly treat that population. So anyone with a pelvic floor is
fair game.
My
baby.
Clientele. Yes.
I'm Dr. Angie, owner, founder, I don't know, Synergy Chiropractic and Sports Rehab, movement specialist. Have a background in personal training, strength and conditioning, and women's health. So understanding anywhere from even preconception to, right, what we're doing.
Right.
The body, going all the way through menopause. I'm a menopause coach as well. And, just movements medicine. So I got to combine everything into one place. And it's freaking fun.
Yes.
So now we want to talk about our knowledge.
Yeah. So today I was going to start talking more pelvic floor specific, but then we'll segue into how exercise, which is physical therapy, but also chiropractic and rehab that Angela does, and how we both address the pelvic floor. So you can just have a little inside look into what we're talking about when we use these different words. So genitourinary symptoms is something you probably see a lot written down about changes during menopause. So what that really means, anything from leaking, urine, gas, stool, dryness, and pain with intimacy. So a lot of the changes that happen to the tissues.
So real quick,
Yeah.
genitourinary, that also means just all of everything that's happening down there.
Yeah, so it's pretty much, so it's the genitalia, so even down to the skin.
Even that helps me clarify even more.
Yeah, genito and then urinary. And I really also include, I don't know what I'm missing in that word, but I'm still including constipation, anything rectal as well.
Yep.
In your pelvic floor, you have your bladder, and this is for the female body, bladder, uterus, rectum. Those are the organs that the pelvic floor muscles, they sit like a sling or a trampoline under those organs. Yep. I should have my pelvis and show everyone. Excuse me. And so the changes that happen hormonally can affect the support those organs have because there are ligaments that suspend them. And then when estrogen's tanking, which happens not only in menopause, also postpartum. So a lot of the things I treat are similar in the postpartum stage.
Yes.
Again, in menopause.
So hold on, let's recap that real quick. So it's the hormones can affect how the sling of your pelvic floor essentially can do its job.
Correct.
Just in the most simple way.
That's just happening without our control sometimes.
Okay.
And so that's why you might experience new symptoms that you never had when you're entering this perimenopause, menopause time. And so the hormones are affecting the ligaments. And so what we can do with our work is help with, we can manually release some ligamentous structure, like do some work fascially on the outside to ligaments as well. But then from a pelvic floor perspective, I'm assessing internally and externally how the muscles are responding, because then that's going to change what we call the length tension. So if there's a tightness or a looseness, I can help assess and then kind of create a plan to create more support there if needed.
Yeah.
So you're not having both a ligament issue and a muscle issue.
Okay, I got that. So real quick, do you can we talk about the hormone?
Yes.
So estrogen is, when we go into menopause, is a decline.
Yes.
So we'll hear about hormone replacement, but not everyone goes on estrogen.
No,
we can get down a different rabbit hole.
Sure, there's a whole other segment we can do on hormones,
day.
and that's not necessarily our scope to treat. That's why I did not.
But just get an understanding of estrogen is typically the most common one that is going to affect and drive these symptoms.
Yes.
And also the development of muscle throughout this time, it starts
to decline.
I'll even have women say to me, I can't build up my leg muscles.
Yeah.
That's one of the biggest things that I have women come in here and they say that. And it frustrates them. So yeah, I just wanted to point that out.
Yeah.
Anything else on estrogen you wanted to talk about there?
Just how, I guess, connecting the dots between, so I almost feel like all this highlight on menopause right now is because we're fed up. Women are experiencing these symptoms and finally saying, hey, enough. They're thinking we need help. And I think in my mind, clinically, the way I see it is, we can't just wait. We have to, so good. Menopause is getting its time to shine.
Absolutely.
I'm picturing Hollywood lights, right? It's famous right now. It's having a moment. It's trending. But really the way to, if you're younger listening to this, or you have kids, daughters, grandchildren, we need to start planting the seeds in our late teens, when you're, been menstruating for a couple of years, in your 20s, when even if you're asymptomatic, but just learning about habits of, because and I know I'm jumping, but let's say you're menopausal and all of a sudden you find out you have a prolapse. There are things that you may have, it's not your fault, but there are habits that we see in the pelvic floor space that don't serve you well, long term, like pushing out urine to pee,
Mm-hmm.
breath holding at certain times. There are things like that if you get assessed and just know how your body works when you're younger, then when these hormonal shifts happen,
Yes.
you won't
Okay.
suffer so much.
Yeah. So it's just connecting to your body at a young age.
There
At the
you
end of
go.
the day, it's just like
Yes.
connect to your body.
I'm more of a word gabber
when you
person.
can. On the summary.
Sum it up.
On the summary. And so it's hard. Right, we can't ask. I couldn't even imagine my 18-year-old self though being like, "Hey, what is my pelvic?" I didn't even know what pelvic floor was at 18.
Totally, but story time. So I was a distance runner from Massachusetts, but I happened to be running a race here in Rhode Island in high school, cross country.
Mm-hmm.
Peed my pants at the end. Like you're finishing.
So crazy, I couldn't even imagine.
And I had no other. So I was going to say I had no other symptoms. I did. I had hip pain.
Mm-hmm.
I was seeing a chiropractor for. I think I was sidelined. You know, it was probably when I went through a growth spurt, a little bit of puberty changes there.
Okay.
And then, yeah, finishing a race. So you run 3.2 miles.
Mm-hmm.
And this one we finished on the track. I think it was like, I forget what school. And so you're running, you're theoretically on your toes, trying to get your last effort in.
Huh.
And I remember almost going backward, like, whoa, something happened. And never had babies. You know, I was 15 maybe. But that's something that I just hope now that I'm a mom or an aunt or just...
You want to be able to ask that question now for your...
I didn't tell anyone.
No.
I ran to the locker room and people were probably wondering, like, what happened to her? Why did she start running? Like, stop on the track.
She's still going.
Yeah, you know, and it had to change and all that. And it wasn't a big deal. And it didn't happen again per se, but it was
That was like one of your first signs. Well, like your hip pain arguably could have been a sign.
Yes, I deal with hip stuff
to
this day.
Yeah. I know you have your own journey. I think we should talk about your journey one
college
day
running
if you're open to it.
Totally, yeah.
Like
but just to give the example of why I'm bringing up at a younger age. And I do have some clients that come in that are teens, and they've done their own research to know they need someone else to dive deeper into why the hip pain's happening, and maybe it's pelvic floor.
So even like moms, right, or listening, and you know you have a daughter, let's say she does track or something, and she's had no trauma to her body, but all of a sudden even she's waking up with knee pain. Yeah. Knee pain is a sign that your hips aren't working well. We can go down a rabbit hole too. We can make sure ankle, it could be a whole thing. But let's say like nothing bad technically has happened to the knees or ankle, and they're having knee pain and they're trying to play a sport. Yeah. That means we have an instability happening in the hips.
Right.
And so it's almost like the chances of pelvic floor to be there could be higher, but they're so young that maybe they're having a symptom of that, but they're not going to tell you because it's like, this is weird. Like at that age, we're not taught to verbalize those things.
Right.
So this would be a good thing of just like, hey, ask your daughters maybe. Like, hey, like, you know, do you experience like urgency, right? Do you experience
Are you going to the bathroom before practice? Yeah. Because you're afraid you're going to leak or it feels funny, or do you have to go again during practice? Yeah. And sometimes then too, we're doing a lot of education on nutrition and hydration and what you're drinking and bladder irritants, we call them. So
yeah, you cover so much with
rabbit
that
hole
too.
There. Yeah.
And I actually just had a recent client, and she mentioned bladder irritation with carbonated drinks.
Oh yeah.
And wine.
Yes, those are the two big ones.
And that's like
bubbly.
Trigger.
Yep.
Trigger. And I was like, oh yeah. That's
all the fun stuff. So it's alcohol.
It's all the
caffeine,
stuff.
Bubbles, chocolate for some, dairy for some, artificial sweeteners sometimes, citrus. So I call it passing the baton. So I do my intake like you, and I'm asking what you're drinking during the day. And so if you're waking up and having lemon water because you hear it's good for your liver and to help go to the bathroom, and then you have your cup of coffee because that might help you also go to the bathroom. So you're passing the baton from citrus, which is an irritant, to coffee. And then you're like, oh, I should have some water. So you have a seltzer at your desk, and then you get a second coffee.
Mm-hmm.
And then afternoon, maybe you have like a sip of water because you're like, oh, picking kids up, or
You're like, oh, I haven't
after
drank
work,
water in
I
a
haven't
while.
had just water, so you have like 8 ounces. And then, you know, whether or not you have kombucha for your happy hour or wine,
Mm-hmm.
a beer, especially now it's getting nice out, people are going to maybe
You're gonna
get
want
more
it.
happy hour stuff.
Yeah.
And you have just irritated the heck out of your bladder. So you pass the baton from one irritant to the next, instead of, I'm not here to take away your fun, even though it sounds like I am.
Yeah.
It's more awareness and adding in, I call it sandwiching with water, or as my sister calls it, a water interlude.
What a great, like, that was a really good example. Because that's like a typical day for a lot of people.
It sure is. And I've done it too
we all
myself.
have. I start with my water, with my lemon, and then I go right to my, I think I've done something healthy.
Right.
And I'm like, all right, let's go to my coffee now because I have something else in my system.
Yes.
Right. And then, like you said, it just keeps going
and you
down
don't
this
quite
hole.
realize. And then, you know, and even also too, I have someone who we're dissecting with electrolytes.
Mm-hmm.
So she's in the health and wellness space, and she'll drink quite a few actually electrolytes, and she even dilutes it in her big water bottle, but it's still kind of talking to her bladder, I think.
Yeah.
And so, yeah, trying to,
you got to connect to your body.
And like, what works for one's gonna, or what irritates one might not irritate the other.
It might not. Like I've even gone to Maryhelen for pelvic floor too. She's done an assessment, and we did a couple sessions, and I can say I'm okay. Like I haven't had really any symptoms, or if I have, I have an awareness of my pelvic floor. Like I haven't had anything major like these. Like I've had low back pain, and we can get into that one day of like my experience with that.
Yes.
So that's why I was like, you know what? Like I trust her. I felt very comfortable. I was like, let me go to you to like actually check it and see like, hey, is there something that we can address here?
Yeah.
I think we were like okay,
yes,
for the most part, but it gave me the awareness. I'm like, oh, this is what you do. This is what it means.
Yes.
And then like just understanding like the different walls and everything, and like where the muscles are.
Yes.
So
like, what the heck is it? It's nice.
It's like no one should be like afraid either of it too. I think people are like, I don't want anyone going internal.
Of course.
Like, when someone asked me, they're like, do you do the clamp, like the OB? And I'm like, oh my god, no.
The forceps.
Yeah.
Some might.
Clamp,
I mean,
sorry.
I don't, and I don't have stirrups, and I heat the table, and you can wear your own clothes if you like, and you can pick the music if you prefer, and I try to really explain what it's going to look like on the phone, in person, again in the moment. And if at any point you guys want to stop, we stop. So it's not like, oh, I know Maryhelen's going to do an internal exam today, I committed. It's not like that.
No,
it's your
it's
body.
Not like that. It's your choice. It's your choice, your body.
So heavy.
But the awareness,
for some people.
That's the thing. It's so gentle. Like it's not what
not what an OB does.
Not what an OB does. And like, I mean, I think we associate pelvic floor with sex.
Yeah.
And you know, sex is not always like this gentle thing. Is that like good to say?
You can say that. No, I always say I'm assessing deliberately, and I'll be talking to you while I'm doing it. Where, if you're having, you know, a moment with a partner, you're being intimate and anything's being inserted, you don't know where that's going necessarily.
Yeah, no.
So this is different.
It's so different.
And you're in control.
So different. And I think that's what I definitely want people to know for pelvic floor too, because they'll even ask me, and I'm just like, no, like what she does, she's so gentle. Like it's not what you think.
It's not a no pain, no gain situation, because there's a whole thing called pain science, which you know too, and there's a feedback loop. So if I create anything that's alarming to you as the patient, I don't want to, because that's only going to create another response where there's gripping and tone and hesitation. So our emotions of fear, anxiety, feeling safe, this is why for birth it's so important, if you're planning a vaginal birth, to come in and work on pelvic floor, because our emotions are stored there. And so if you're feeling out of control, so birth, stressed, anxious, fearful.
Yeah.
And of course, I'm not even touching on, because you can't just quickly do a drive-by of talking about any sort of history of abuse or trauma, but I do work with my clients on that too.
Yeah.
We are going to grip. They have studies, they've done it,
Mhm.
where they inserted a probe into a group of women and showed us different images. And our pelvic floors grip in those moments of not feeling safe.
Yeah.
So if in a pelvic floor exam you have pain or you feel uncomfortable and don't feel safe, then it's just going to be exacerbated the next time, right?
Yeah,
So
absolutely.
that's why it's a no pain, no gain. I work really hard to create
Absolutely.
an environment in a relationship where you feel comfortable.
Absolutely.
So, yeah.
I think I have 2 questions here
Yes,
too.
you're reading my notes.
One, not really, but one.
You look
there's
like you are.
also, now if you see, and we just talked about this the other day, a standing exam.
Oh, yeah.
So let's talk about like why this is important too, for active women. So I see a lot of active women. Can you explain why standing and also being assessed that way is really important?
So if you really break it down to, even if you don't identify as an athlete or an active person, I bet rarely any of you listening are laying in bed all day.
Facts. Yeah.
So if you are not having your symptoms laying down in bed, why would I only examine you that way?
Absolutely.
And so, yeah, there are some patients in here where we don't get to standing or we do other things, but I really try for the majority to incorporate at some point a standing internal assessment, because what I'm feeling is when you're standing up, so this is involving your feet, your knees, your ankles, hips, lower extremities, your core turning on, what happens? So first I'm just feeling. And then I ask you to do different things like pretend cough or sneeze or laugh. And normally we're nervous laughing together, because every time I do this, maybe 5 times a day, every day, and it can still be like, okay, this isn't typical. I get it.
I did a standing one.
Yeah.
I was just like, okay, just tell me what to do. Like, yeah,
I mean,
it's different, but
it doesn't have to be. I think I really try to bring levity to it, and try to make you feel comfortable as the patient. Absolutely. But the reason behind it is most of my clients are symptomatic, maybe as the day goes on. Yes, maybe with running or lifting a certain weight, lifting their baby, and then we can even get into like squat positions, because sometimes we're talking about toileting things.
Oh my God, yeah. That too.
So
there's so much.
Yeah, and I want to help you. Like I did not go to school for thinking I was going to be a pelvic floor PT.
And not for nothing, in school, they don't teach you maybe like a slide.
Nope, I didn't even get one slide on the pelvic floor. And for our cadaver lab, we just sort of skipped. We did external, so glutes and stuff.
Yeah. My cadaver lab, yeah, there was no pelvic floor.
And pelvic floor then is considered a specialty. And it is, yes, but I can think of so many patients when I worked in orthopedics and sports medicine. I can visualize this woman. I don't remember her name, and she would work so hard to come in on time, consistent, bring her other kids, chronic IT band, hip symptoms. Yeah. I know I did not get her to the 100% because it still haunts me, and I did not know to refer her to pelvic floor PT. I didn't know. I thought pelvic floor PT was for post-oncology, post-severe prolapse surgery, like the last end of the line type thing. We are so not that. We are that as well. I do work post-op for sure.
Absolutely.
But this was a mom who's like me, like postpartum and needed help. And still haunts me. So I hope other providers might be listening who aren't pelvic floor PTs just educate on
and like
when to refer out.
Yeah, like you'll know there's certain progress that you're making, and like there comes a point where we're just talking about a patient I had that need to go to pelvic floor therapy. Yep. And to get them over the line.
But sometimes it takes the patient, unfortunately. So that was me. I graduated from PT school from a great school, but still we didn't cover pelvic floor in 2009. And where was I going with this? I didn't learn about what we do as pelvic floor PTs fully until maybe 2014 after my second birth. So there are providers out there who, so I was a PT and I still didn't know.
Yeah.
So it just means even if you're OB, your GYN, your MD, your functional medicine doctor, whom I miss, physiologist, physiatrist, whoever you see as your expert, if they're not saying you need it, it doesn't mean you don't. Am I saying this in a negative, passive way? So it can be not all the experts even know what we do.
Yeah.
I did not know what we do until I became the patient.
Yes. You had to go through your own experience to understand, like,
but that's so...
It's so common. That's how everyone...
And now Instagram and Facebook, that didn't exist when I was...
Yeah, there's so much information out there and understanding, like... Now I think so many more women are so inclined to go now.
Yes.
I think there is a little bit of disconnect too, though, because I think a lot of it now is around pregnancy and postpartum.
Yeah.
Where it actually, like, and that's what we're like, the perimenopause and menopause should actually be a time as well that it needs to happen.
Yeah, you got to check in, even if you already saw us earlier too.
Now, okay, so just to connect with that population of peri and menopause, what do you think is the number one symptom you see in that age group? And we can talk about some examples.
I would say leaking and then pain with intimacy.
I was just going to say,
those are my top two.
Let's talk about pain with intimacy real quick.
Yeah.
I think that's like, and you know what? I have some clients, and I was just telling her that I had to switch my intake form and certain things with my process onboarding people because they're having pelvic floor symptoms and they don't tell me till later, and they'll tell me some stuff has progressed, but then there's just like the one last thing. And if I would have known that in the beginning, I'm like, could I have changed a treatment plan or could I have referred out faster? You know what I mean? Because I spend about 3 to 4 months, even 5 months with people at a time. Yeah. So let's talk about that pain with intimacy. As I say, like, that's probably one of the number one things I do see in perimed when I have people telling me about their symptoms.
Yes.
It's that.
So again, it's another hormone shift that's usually the primary driver. And that creates vaginal dryness. Yep. So that from the get-go is going to change how it feels. So we get super specific with pain with intimacy. So if you're in a hetero relationship and because I also talk about just also achieving pleasure. That's a whole other physiology thing that we can dive into. Yeah. But if we're talking about just pain at the introitus, it's called. So with entry pain versus deeper pain. I keep hitting my microphone. My hand. It's like Talladega Nights.
That's why I'm holding this, because I talk too much with my hands, so I have to keep this.
If you haven't seen Talladega Nights, my friend, can I give a little quick side story? Yeah. In PT school, we used to give these presentations, and they meant so much for our grade. Yeah. And my friends would sit, and we were the back row kids in PT school, and and she would go like this to try to get me to laugh, because Talladega Nights.
That is so awesome.
Like,
I would have been so pissed. I would have been like, stop.
Yeah. So Jenna did that.
Jenna, I hope you're watching.
Yeah.
Thanks for supporting us. Yes. 2 people watch. 3. Our moms, Jenna.
Okay, so intimacy, I was talking about pain at the opening. So, and I know I keep paralleling this to postpartum. Okay. And I'm sorry, but postpartum, if you are lactating, so whether and even without it, in those first couple weeks, if you're choosing to wean and go to formula early, and I should say it's not always your choice, but if situationally you have to do that, you still have a bit of estrogen tanking early, but the estrogen stays away longer when you're lactating. So that's why there's a lot of discomfort postpartum outside of any vaginal
so I didn't know that. So it's really good.
Oh yeah, it's a huge thing. And so I always equate it to my new moms. I say it's like you're in a temporary state of menopause, because of hormones, and they're mimicking similar trajectories. Not the same. I know it's not the same. And again, this is not, I study hormones because of what I do, but I am not that hormone expert and don't claim to be.
You just understand what it does physically,
yeah,
and how we can support you, right?
Yes.
So anyways,
so that. So with now your perimenopause, and you know what's tricky with intimacy too? It is not so black and white. That's just like, oh, your estrogen tanks, so you're dry.
Yeah.
It is. So with intimacy, there's, especially for the female body, emotions are huge. Rest, huge. Feeling supported. It is such a, I'm blanking, brain fog on how it's a not discipline, but a
it's a holistic, like,
for us as women to have
I mean, even an orgasm,
to be best set up. Yes,
it's more like your mind's got to be in it.
100%.
Right? Yeah, it's not,
and not for everyone. And there's sex therapists. I've listened to different things and read about how there are different people in this. So some people are reactive, or I forget what it's called.
I just listened to a podcast the other day.
Yeah, maybe we listened to it.
But yeah.
But the majority, and so when you're in your 40s, I'm not saying even outside of having children add to the chaos, right, of life. But even if you are not a mom, you're just then juggling a lot with work. You might be taking care of your older parents. Because we do age, like, we are not saying you're not going to age, but you might have aches and pains, right? And that can just be, and it's that identity, it's that midlife crisis phase, right? You and I were also just talking about that. I think I don't know if midlife crisis is at 50, but rarely are we living to 100. So, right, midlife is 40s.
Yeah.
And that is going to affect your libido and wanting to engage in feeling good. So then also for us too, going through menopause, there's the weight changes, there's new acne, there's itchiness in weird places, there's waking up from 1 to 3 a.m. So yeah, usually engaging in intimacy is not top on the list.
It's not black and white by any means. And then when the hormones are affected on top of that, then you start spiraling down, is what I'm understanding. With women, of just like, what am I doing wrong?
Yeah.
But it's a lot of gray areas to really
so much
dive into.
And so it's holistic, like you said. It's not just the Viagra solution for erectile dysfunction. It's not.
Could you imagine if we had that?
Well, one, wouldn't it have been awesome if before Viagra we were actually addressing women's health?
Crazy thought. But right, it's those statistics, right? Most of the studies that were ever done in a certain time frame were all men. So like, that's why we got pushed to the side for so long. Obviously there's advocates now and stuff like this happening.
And this is a crude way of, gosh, it was again another podcast. This is not my original thought, but the doctor was saying, oh, I know who it was. I can see it's the one I was telling you about. It's a male podcaster. He's holding a carrot like a phone. Dr. Ali Quick in Newport told me about him. Anyway, it will come to me. And I think it was Dr. Mary Claire Haver saying essentially it would be like menopause for women, or for men would be like if your balls just then were empty and useless and just hanging sacks that you didn't want to use anymore.
It's kind of funny.
And he was like, yeah, you're right. Like, we don't know what you're going through.
No, it's so crazy.
And like, imagine the outrage, right?
Yeah.
So anyway, I know we're finally talking about it, but what then, I think people want to know, how does pelvic floor PT help with intimacy?
Yeah, how do you support when there is painful intimacy?
So one, talking to you and educating you about what you can ask your providers for. So whether that's estradiol, topical estrogen, just opening up that conversation for me to say, hey, there are experts that you can go ask these questions, let them know, and see if they think it's appropriate to prescribe anything. Sometimes there's vaginal Valium for pain and just to get over the hump. And there's even things like Botox to the pelvic floor, which isn't as common, but just knowing. So just saying, hey, did you know all these things exist? Talking about that pain science loop, like I just talked about, where this is not a lay there and suffer through it with your partner because you should be. It's actually going to continue to make this experience worse for you. And then in PT, there's so many habits I talk about. So bowel and bladder, like toileting habits that might not be serving you at the pelvic floor. Breath work, tension habits, where you might be chronically clenching at your teeth, shoulders, stomach, glutes throughout the day. I do it too. Look at me right now. I'm up on my toes.
I just checked my toes are clenched and my stomach's clenched right now.
So like doing these check-ins so you're not creating more tension as the day goes on, which is not beneficial for welcoming anything into your pelvic floor. And so I also do, if you're open to it, internal assessment. Typically this is more laying down, unless your goals are standing. People have sex standing up, but we start with laying down and finding if the left side or the right side has any pain or tension. What's happening? Sometimes it's not a physiology, like a length tension or a trigger point issue. It can simply be needed repeated stimulus. So my finger in a slow and controlled way. And training the patient to not be sucking in at their stomach. So a lot of times then, hey, you've added that 10 pounds of menopause weight, you're self-conscious, your partner doesn't tell you how awesome you look every day. So then, clothes are off.
We could literally do a full episode on like women as society, how we've all sucked in. I literally think that's what my back problems came from when I was younger.
There's so much
get into
work
that one day.
I do to abdominal walls and
we have to get into that one day.
And letting it go. And your belly is supposed to be soft. We are not supposed to have these washboard abs unless some of us do. I don't. Some people do. But so when you're trying to release the pelvic floor, which is important for pain-free intimacy, if you're sucking in at your stomach, that's going to work against you. And then there are things called, so doing graduated internal work, if that's necessary. There are things called dilators. So a lot of my clients do really well because then they're doing it as their home program on their own at home. So then they're in charge. It's not waiting for me as the PT or their partner and sort of just like, when is it going to hurt? They're the ones that are in charge of depth and how long or what angle, and it can really help with nervous system response to anything inserted.
Awesome.
So a lot of education on that. Strengthening the hips so the pelvic floor can learn to let go.
We got to stop the clenching in any type of way that we possibly can. Get good glutes.
Yes, look at those babies.
We want nice glutes. Glute work.
And then positions too. So just like I talk about birth positions, because you're trying to birth a baby. So welcoming something out, when you're welcoming something in, it's the same idea. So different positions that you can be in as the woman, and hip range of motion and how that affects whether you're internally or externally rotated,
so
what that's doing to the pelvic
hip mobility
floor. Yes, so I talk about these things, and it's not in a crude way. No one has to tell me what position they're in with their spouse. I'm simply just sharing, or a partner, I'm just sharing what I know. And I try to make it really seem very just black and white, and I'm not a sex therapist, so I'm not getting into anything other than that.
But it's like the physical of how your body is, like how you can really talk that out with someone and get them aware. Like, I think like the topic of this is like awareness of your body is so important, and just understanding how you're moving, how everything is working you can connect to it. Like things can change for you throughout later on in life, and like when you're going through menopause and you're having these hormonal changes, that like the hormonal, like with the estrogen and everything, that can be a barrier in your sex life, let's say. But we want to just like, have we covered everything? Right? Have we gone to the connection, and like we just have that one thing of just like, hey, you assess them and you're like, okay, all you need really, like based on everything I'm finding, everything seems good. here's a specialist for like
Sure.
hormones,
Yes.
for example. So I think that's what a good thing is. It's like you're going to give the awareness physically, and like Maryhelen will be like, okay, this is where you need to go afterwards, you know, just to optimize the body, essentially.
And lube. I hand out lube like crazy.
She has tons
I have
of
a
lube
lube
in
drawer.
her. It's awesome.
Because yes, it's not always going to be as lubricated as it once was,
No.
and that's a whole other, you know, getting into ovulation and what happens with that. So, and if you're no longer ovulating, so are you? See you later, ovulator. Are you creating that natural lubrication?
Yeah.
So there's that piece too,
Yeah.
and just normalizing it.
That's what it is, and like that's why we want to talk about this, because it's like it's okay to talk about this, and understand that this is a normal occurrence that happens with women, and like you're not broken by any means.
No,
it's just your body's responding to changes in life, and we just need to learn to combat it, so that, you know, from first episode we're not Aunt Mary in the hospital with a broken hip. You want to engage and you want to understand what your body's doing to just help you with the longevity and have less painful sex throughout your life. For example,
you don't want that.
That was really good.
Yeah,
I like that.
Does anyone? So we weren't planning on only talking about sex.
I kind of like think we should keep it at that though today.
Yeah.
Do people ask you? Leaking one.
So do people? Yeah, we could talk about leaking another time.
Yeah, we can do a whole episode on that one.
We like to dive into just the TMI right away. Do your patients talk to you about pain with intimacy?
Like I said, it ends up being later.
Yeah.
It's not right away. But like I said, I changed some of my intake and how I ask. And you know what? Some people don't understand that is like a pelvic floor symptom either.
Right.
Especially if they had it for a long time. They just like, but then I know people that are like super like, oh no, I've been going somewhere, like I've been trying to work on it, which is great.
Yes.
And
but they might not connect it to the hips.
But they
like
don't
how you can help.
Yes.
Too.
So they don't connect it, and that's where I like to be like, okay, you know, the education of your pelvic floor is going to try and make up for the lack of what's happening outside, you know, the major muscle groups of the hips and the glutes. And so being able to engage and get you really strong in these other areas is going to help assist whatever else you're trying to do for like, for example, painful sex, and like trying just to bring everything together.
Yeah, because I don't see you and I as two totally separate disciplines. I know you don't do internal exams, and I know I don't have a squat rack in my room. So like two just examples of how we differ. But pelvic floor is not just, when I say it, and for today, I'm talking to you about those specific muscles, not just this.
The sling. Right? It's not just
it's your core, your diaphragm, your hips, your glutes. Glutes are your hips, your abdominals.
There's so much to cover. Back muscles. And it's like, that's where we get specific, where it's like, I'm not going to sit there. Like what she just explained, I could never sit there for a whole session and be like, hey, this is what's going to happen. This is how you should do it. I'm more of like the movement of just like, hey, this is how you're going to get stronger. This is how you're going to get more mobile. This is how you're going to keep your lifestyle and enhance your lifestyle. Mine's like a movement is medicine type thing, where it's awesome with Maryhelen. She's more of the like, hey, let's dive into a little bit deeper of like, how would I say it? Like you said, like.
Yeah, you're right. Because I was that in my ortho time.
Yes.
So sometimes I get there depending on why people come in. But when we're talking specifically about
daily
leaking
daily
or
habits
intimacy
and all that,
or constipation, if these are your prime reasons for coming in, we're going to really get into the habits.
And just even on a deeper level, you can get, she gets on the emotional level too, which I mean, we all do as providers, especially like us too, like we're spending an hour with you.
Right.
So like we get to know the person, we understand.
Yeah, you made me cry in my visit. I mean, I cried because I felt safe in your office.
I remember when you went internal for me, and like it felt emotional. Like I was like, why do I feel like I want to burst out crying right now? Like it's a real
relief
thing. And it's like, and that's why it's like to connect your body with your emotions too, and how important that is.
The issues are in the tissues.
Yeah. And so like we can't get that with 10-minute appointments. I'm sorry. Like,
or like in my world, the 30-minute
yeah,
PT visits.
and it's like it has to go beyond that. And if you want a deeper meaning of an understanding of your body and connection, like you have to take that time and investment to be like, okay, like this is what I need to do to live better.
And it gives us time to really know you.
Yeah.
And know what questions to ask.
Huge benefit to that.
Yeah.
So yeah, that was
hopefully.
Hey, we hit the 45-minute mark
this
again.
Was helpful.
I literally like that topic.
Yay! Good questions.
And yeah, so she's the expert with that one for sure, because that's definitely internal awareness. But then
I get really passionate about
then
it
it's
too.
like, okay, more of the like, hey, how you moving? Like, you know.
Yes.
So and she, like, Maryhelen is very passionate when it comes to this, and I always ask you as many questions as I can, and just like really want to understand this even more, because it's like we're helping women as much as we can, and so we have to try and help in every avenue. And like create that village. Be like, hey, you need to go here to understand what needs to happen next. You know, sometimes we're only just like one piece of the puzzle, and that's okay. But like, I don't know, it's pretty awesome. I love helping this population.
You're good at it.
And getting into it. I just love booty, so we have to keep the booty strong.
Yes, I need to work on mine.
At the end of the day, having a strong booty is key.
100%. And Angela's the booty expert.
I am. You can ask everyone. All right. Well, thanks for tuning in.
I didn't spill my green tea.
I surprisingly didn't even finish this. I'm gonna chug this little shot glass. Get out of here. I'm gonna keep it though every single week.
Oh my god.
Have a great day.